All right, we're going to try this again. Like I said, I fake it till I make it. So let's see if we can figure this out now. It is not letting me find her in the search bar. So weird. Someone help me. Okay, let's see. There she is. Okay. I am going live with Dr. Karli Goldstein today. We have a bunch of questions from everybody that y'all submitted in my question box, so we'll answer some of those. There she is.
Hi guys.
I could not figure it out.
I'm not an Instagram master here, so as you
Same.
guys can tell from my feed. So does my screen look dark?
It looks fine to me.
Maybe it's just because I'm on the bottom and the text is coming up above my mouth. Maybe that's why I look darker. Okay, light is okay.
Yeah.
Okay.
Looks good to me.
Okay.
So do you want to do like a little brief introduction of who you are and all that good stuff?
Sure. Yeah.
Okay.
So I am Dr. Karli Provost Goldstein. I am a endometriosis excision surgeon, fertility surgeon. I also do myomectomies, hysterectomies, and I do comprehensive gynecologic care for patients with pelvic pain, patients with hormone dysfunction, patients that are going through infertility and need advice and someone sort of to look macroscopically at everything they're doing and everything they're trying. I'm not an IVF doctor. I am a surgeon, but I went through many years of endometriosis myself and more than 10 rounds of IVF and a lot of different doctors over the years. And so I'm happy to always give input to people on their fertility journey and kind of go through all the very different options and do it in a way that's not really biased because I'm not really doing the IVF myself, right? So,
which is nice.
Yeah, so I'm passionate about that because I know it's a long, hard road, and so yeah, that's sort of in a nutshell. And I believe in comprehensive care with gynecology and merging Eastern and Western medicine, and
that's lovely.
Yeah, and that's sort of what I started my practice to really work towards is that I knew in my life and my journey in medicine that I really needed things like acupuncture and nutritional support and integrative care and people that really listened and hormone balancing. And so I wanted to make a place where patients can come and I can give you sort of hand-holding on that and then all direct referrals with people that I really support and trust and have been awesome to the patients. And so in a space that's very not confrontational and not about ego and very much about listening and providing, the best care and advice. So that's it.
Lovely. And then your practice, you're located only in New York, is that right? Esse Care, or you have multiple locations?
I have multiple locations. So I am in New York primarily, but I have family in California and Texas and the South. And so I do have licenses in multiple states and I've expanded to LA and I see patients there every few months and perform surgery there. And I currently have, Cedar Sinai, Marina, and some surgical centers in LA, and then hospitals in New York and New Jersey, and hopefully Connecticut soon. And then the South, I'm not operating there yet, but seeing patients there. And then hopefully that'll be coming in the future, but we'll see.
Awesome.
Depending on travel schedule. And if not,
all the things. Awesome.
Yeah. So yeah, I'm always happy to do telehealth and then, figure out the planning from there. And so with your case, we're doing a look at sort of preoperative counseling today. And Tara is going to be flying in for surgery. And so we're going to go through all of the things that we do at Esse Care to make this not a difficult or stressful process when you come in. And people may think that it might be to fly in somewhere for surgery, but we are trying to take all the headache out of it for you so that, things are really taken care of and you feel ready and supported and have all the resources you need.
That was really surprising to me, and that was very important because when I thought about flying somewhere for surgery, I was very overwhelmed and anxious about it. Um, and met with a couple surgeons, and your everything that you have in place makes it so simple. Like you have everything streamlined. Your office staff is amazing at like coordination and communication. I was very impressed
Yeah.
because that's a big thing to, as a patient, to think about, like not only having surgery, but flying to and from, being somewhere else, like that you have no clue where you're going.
Right.
So that
Absolutely.
was really important.
Yeah, absolutely. And I think one of the things, my practice right now is actually in Westchester, so it's outside of the city. And the office and hotel where we have like a corporate rate at the hotel right next to the office, and they actually have like 1 and 2 bedroom apartments with little kitchenettes. And so it's really like 15, 20 minutes from LaGuardia. So it's actually quite easy. And then it's also 15 minutes from the Westchester airport. So some patients have even flown into the Westchester airport. And we have, excellent drivers that can come and pick you up at the baggage claim and, and really organize everything to where you don't have to deal with the intimidating mess of Manhattan. You can be in a very reasonable place. And if you want to do a little trip there on the way or from the train, it's fine. But if you want to just stay in a little bubble in Westchester, it's also fine too. And so, yeah, and I can coordinate it to where, rental cars and stuff like that are not even necessary. You can just focus on the surgery itself and coming to the appointments, and that's it, healing. So
Yeah. And I thought that was great. And that, like, there's actually a little kitchenette where you can make things because we're looking at staying there for a week. So
yeah,
it's
yeah,
like nice to have. And there's a grocery store with everything right next to the hotel. I mean, you just have it
yeah.
all figured out. So that was lovely.
People love that Wegmans. That
Yeah.
Wegmans is great. So yeah, absolutely. No, it's important, and it's nice to have all of these things set up. So you have the soups, and your family member or partner, whoever's coming, can make like a little walk to the grocery store and get some things, and so it's nice. It's a nice setup. It makes it pretty easy there. So
Yeah. And I didn't even have to, we didn't have to do anything. Like you
yeah,
just told me what to do and it
yeah.
happened and it was lovely. And I
Absolutely.
like
No, we
that
try
with
to.
all the other things we're
You
coordinating.
have enough headache going on, so it's better to have something taken care of. So
Yeah, it
yeah,
was really nice and surprising and refreshing.
yeah,
So, yeah.
absolutely.
All right.
Yeah,
And then, so I don't know if you want to talk about, I have a whole bunch of questions that people submitted to me, and I don't know if you want to go through those first. Um, and then kind of talk about my case after with the amount of time that we have left, or
sure. Or we can do whatever you like. We can do yeah, either way. Either way. It
okay.
doesn't matter.
Um, will you first talk a little bit about the difference between just an OB doing surgery and an endo excision specialist doing surgery? Because that, I didn't know that was something to take into consideration when talking and looking at doctors to do your surgery until like recently. And I've been dealing with endo for years, and that was something very new to me. And I think that's important to talk about.
Sure, absolutely. So most OBGYNs receive some basic training in endometriosis. Unfortunately, it's not really what it deserves given how prevalent this disease is. When we say it's probably 10% to 12% of the population of people born with a uterus. Unfortunately, it's sort of a small section of what training you receive. even in pathology in medical school, there's like a little picture dedicated to endo and some microscopic views of how the cells in the lining of the uterus and the cells in these disease look similar in the microscope, right? But there's not a huge section on the pathophysiology and on all the different organ systems that this affects. And that's a shame. I wish it was better. And, there's a lot of work being done. And, when I can, I do medical student or nursing student education things, but that's a whole other subject, is that there could be a lot more time dedicated to endometriosis. And there's a lot of work dedicated to like lupus and things that involve multi-systems, but the actual prevalence of lupus is way less than the prevalence of endometriosis. So, but unfortunately,
that's interesting.
Yeah, but unfortunately, like certain things in med school are like a hot topic. Lupus is one of them because it affects multiple different organ systems in the heart and the kidney. So then they like to bring in all the different lectures for all the different things that lupus could affect. But endometriosis also affects all different organ systems, and it only gets like a very small little shot out in school. So, and in residency, it really depends on where you do your training as an OBGYN. Most residency programs are more obstetric heavy, and it depends on the program how much surgical exposure you have. You're required to do basic amount of surgery and basic amount of hysterectomies and C-sections and oncology rotations and things like that. I trained at a place where there was a lot of endometriosis surgery and an endometriosis expert surgeon. So I happened to be fortunate and lucky in that regard that I had a big exposure. But in a lot of residency programs, you may not necessarily have that exposure. And then anything that you're doing with minimally invasive surgery is dependent on the surgeons at that program that are operating in it. And so if they're mainly doing robotics or mainly doing robotics for fibroids or something like that, and they're not necessarily doing a lot of endometriosis, then you just may not have the exposure in residency, right? And so it's hard to know that about an OBGYN, right? And so the best thing you can do, if you're asking, is your OBGYN is, do you do these cases a lot? Do you do endometriosis a lot? Do you have cases of endometriosis that you do that are advanced stage that involve the bowel and the bladder and other things? And how do you go about that? Like, do you have a team? Do you have a bladder surgeon, a bowel surgeon that works with you? And you can sort of gauge from the responses if it's like, well, no, the advanced cases I send out, or if it's bad, then I'll just get out and not finish the case or send you on or something. Then you can kind of gauge the experience and the level of comfort if cases are harder, than expected. So it's always, I think, important that, if someone is not really comfortable with the surgery in advanced cases, then it's better off to avoid surgery and then try to find someone that is an expert surgeon. And there's always resources for that, even if you're looking to go, in network and if at a university or whatever. I mean, there's other places that I can point people towards as well, that would still be better than having surgery that could be incomplete, if that makes sense, or surgery where someone isn't really ready or experienced, but then they do it and then they go in, take a look, and then come back out and then try to put you on Lupron or birth control or something like that. So those instances you're still put out to sleep with anesthesia, general anesthesia, and we shouldn't take that lightly, right? It's still a big risk. And so it's still important that every time someone puts you to sleep with anesthesia, that the surgery itself is worth it for you, right? Yeah. So.
And that was my situation too.
Mm-hmm.
So I experienced that personally. And then now I'm like, after rounds of IVF and estrogen, I'm like, oh, this is bad. Because like looking back at my first operative report from September, I had a lot of disease left because my surgeon didn't feel comfortable removing from my bowels and my pelvic floor, the cul-de-sac, I think is what she called it. So now we're looking at doing it a little more comprehensively.
Right. Absolutely. Absolutely.
So, yeah.
Yeah.
And then the questions that I have, do you want me to just read them off and you can answer them?
Yeah, sure.
Okay. So the first one is there anything I can do to prevent endometriosis from returning after excision surgery?
Yeah, so that's a big one. There's probably lots of things. So environmental, food sources, nutrition things, it's always good to focus on that. So low inflammatory diet, lifestyle, acupuncture, getting exercise like yoga and things that will help you. Pelvic floor therapy can help down-regulate the pelvis if there's a lot of tension after surgery or even before surgery or painful intercourse, and then you have surgery and it gets better, but there's still a lot of tension there. As far as reducing the recurrence of endometriosis, Tara, you and I have talked about this a lot. There's not, unfortunately, even birth control and Lupron, they're not perfect, right? They're not, they don't necessarily prevent disease from forming, and they don't necessarily prevent it from progressing. Meaning, I've seen patients that have been on these medications for years and years and years, and they still have stage 4 endometriosis with bowel invasion, right? Now, there are patients that have endometriosis excision surgery and they do go on birth control or IUD or something like that to manage the amount of heavy bleeding they have. And that does have a role and a benefit, and it helps prevent some heavy bleeding. And if they don't like having ovulation or they have a lot of pain with ovulation, then sometimes low dose birth control can help them to prevent ovulation so that it keeps them from forming new ovarian cysts, right? So these medications have their role for very specific things. And so they don't necessarily prevent or stop endometriosis, and that's very important. And some patients may react negatively to them, and we don't know if that's even a trigger for them. But I like to say that I'm, very open-minded about it. Even after surgery, I don't have a one-size-fits-all for every patient. Every case is completely unique, and it depends on even the diet stuff, what you tolerate, what your allergies are, what your sensitivities are, right? The medication things, what you've been exposed to in the past, what's worked, what hasn't worked, So every single thing is not, I can't give like a easy blanket response for every single patient, right?
Yeah.
But I do think that nutrition, environment, all of these things are really important after endo. And if we're doing fertility treatments, that we also think about how much estrogen is given and how much unopposed estrogen is given, whether for fertility or for perimenopause or menopause. Estrogen alone and putting estrogen into very high levels can increase your risk of recurrence for endometriosis, right? And so everything done with hormones should always be balanced in an endo patient with progesterone. And in fertility, there are ways of doing fertility with a fertility doctor who's an expert in endometriosis and offers several plans for endometriosis patients where they can keep your circulating estrogen down lower. So those are important. So
Awesome.
I know a long-winded answer. These answers are, it's hard sometimes to give a short, quick answer.
Yeah. And if people do want to look into that, like a more personalized plan, they can always contact you.
Of
And
course.
that's what
Absolutely.
you do for.
Yeah, absolutely. Even if I don't do surgery, that's okay. Sometimes patients come to me after surgery and they do it to have these opinions after surgery because they felt like they didn't get a really good review of their pathology and their pictures and what actually happened and then what their plan is. And I do that too. I'm happy to do that. So.
And you can do that with any patient via Zoom, right?
Absolutely.
Okay.
On telehealth.
Okay. Perfect. All right. And then question number 2, what do you recommend to patients trying to conceive with adenomyosis, fertility treatments, and long-term advice?
Yeah, so it's a tricky one, right? So adenomyosis certainly can make it more difficult to get pregnant. It doesn't make it impossible, but it can make it more difficult. And, I've seen good outcomes. I've seen patients with poor outcomes. I've seen patients with sort of all different things happen with adenomyosis, right? And so it really depends on your whole history and what you've been through and how invasive the adenomyosis is in the uterus. And we have to look at all of that with imaging and looking at, a complete history of what you've been through, and then sort of look at the pros and cons of everything. And if they're doing IVF, there are protocols that you can do to down-regulate adenomyosis before doing the embryo transfer, which I have seen personally with patients be successful with even severe adenomyosis. And so that's exciting.
Yeah.
And that can be done with your fertility doctor. And for patients that are trying on their own, you know, I would recommend, if it's failing or you've had multiple miscarriages, it is important. And I think it's very useful at least to even have an opinion with a fertility doctor who's very knowledgeable with adenomyosis and the options for it. You know, adenomyosis can cause increased risk of abnormalities with the pregnancy. So placenta can implant in the wrong space. It could cause early miscarriage or second trimester miscarriage. And, you know, endometriosis and adenomyosis both share higher risk pregnancies, like higher risk of gestational diabetes and placenta accreta, placenta previa, and even, you know, preeclampsia, things like that. So there are higher risk complications that could develop. It doesn't mean that they'll happen in all patients, and many patients go on to have a normal pregnancy. But I always, for my patients, prefer that they have a high risk doctor following them, a maternal fetal medicine, and called an MFM. I always think it's better to have someone a little more TLC for these patients when you've tried for a long time,
Yeah.
than just be monitored every couple months or something.
Right.
So,
Okay. Cool.
mhm.
Right. This one's a good one. I see a lot of people that need multiple surgeries in a short period of time. Is that a bad surgeon or just bad luck?
Uh, yeah, good question.
Yeah.
So, if they're having repeat surgery like every year, that's not a good sign, right? And if they have surgery with a surgeon who says, oh, you're going to have this surgery, but you'll be back every year or two for more of these surgeries, that's not really a good sign. So,
Red flag.
yeah, that's a red flag. And many times when surgeons are doing ablation or
Right.
just sort of fulgurating, it's called fulguration or ablation of endometriosis, and it's where they just go in and burn a couple spots of the disease. This is not really true excision of the disease, and there's usually disease left behind. And, you know, you cannot burn lesions on the bowel. You cannot burn lesions on the bladder. It will burn a hole in these places, and, you know, it would not be safe for the patient. You can have a leak. And so typically those kind of surgeries are incomplete, and that's why they're going back so often for surgery. You know, I prefer, if I operate on someone for endometriosis and we do a quality excision, hopefully they will not come back except to see me to say hi and do like a yearly exam or something if they want to come, or they're coming back in their 40s, they're done with periods, want a hysterectomy or something definitive at that point. That's a different case, you know, at that point. So most of the time, I would not see someone back for surgery again until 5 or 6 years down the road. And it would depend environmentally. If they've had a lot of IVF and estrogen exposure, then they may be more likely to have a recurrence. Whereas most cases, after deep excision surgery, they really don't have a high recurrence of endometriosis in the pelvis, typically. Every now and then there's a divergence and an outlier, and someone has more advanced disease to begin with, or someone really does have quick recurrence times, like within a year or two. But we have to look at all the medications and what they're on and what things they're doing environmentally and food-wise, and see if there's some other risk that's happening that's giving them more estrogen exposure, right?
Makes sense.
Yeah.
Okay. Pain with intercourse is still happening even after laparoscopy.
Mm-hmm.
What can we do?
Good one. So after laparoscopy, especially if they have excised disease in the cul-de-sac and the back of the vagina on the abdominal side, and there was disease positive for endometriosis, hopefully it was all cleaned out. But even if it's all cleaned out, that could be an excellent time to try something called pelvic floor therapy, where it's actually a physical therapist that does work with you with internal exams to help down-regulate tension in the pelvis and the pelvic floor and the musculature of the pelvis. A lot of times with things like endometriosis and with painful intercourse, subconsciously, the patient will tighten up and they don't even realize they're doing it. And that's a response to the body really being in pain and having trouble. And you have to work with someone to help you sort of down-regulate that automatic response, right? And so that's where I think pelvic floor therapy has an excellent role, and sometimes they'll see you pre-op and sometimes they'll see you post-op, and they'll actually be able to tell the difference in the fibrotic tissue in the back of the vagina on their exam. And we can certainly feel it as surgeons. And so, and I can see, you know, there's little tricks, like very little tricks that you can do, even with breathing, that I teach patients in the office when I'm examining them. So if you're going to have a speculum exam or a pelvic exam or intercourse, and you're noticing that things are really painful and you're tightening up, then one like very cheap trick is just to put a hand under your bottom, under your buttocks. And if you're sort of taking shallow breaths or short breaths and you're in pain and your buttocks is tensing up, then that means actually your whole pelvic floor is contracted. And so one of the best things to work on to downregulate pain is to take a deep breath in and then breathe out really slowly through your mouth, and try to feel that your bottom melts into your hands. And when you do that, your whole sort of lower pelvis will sink down a little bit into the bed or the mattress or the clinical bed if you're having an exam. And that's one way to sort of try to relax everything so that it will be more comfortable. Okay. And I'm not a pelvic floor therapist, but these are just like little tricks, and there are many things that they can teach you that even if you go for one visit, then they'll be able to teach you some tricks to do at home to make things more comfortable.
Awesome.
Yeah.
That makes sense.
Mm-hmm.
Cool. All right. This is a good one. Can endometriosis only be diagnosed and treated surgically?
So good question. Most endometriosis is diagnosed and treated surgically, right? So we can have a very strong suspicion of endometriosis whenever we see, for instance, an ovarian cyst on ultrasound and MRI or CAT scan, and an endometrioma cyst that looks like typical endometriosis fluid. We'll see it on imaging, and it has sort of a speckled appearance, and there's this typical appearance that it looks like on MRI and on ultrasound and CT. Even though we can think with imaging, oh yeah, that very much looks like endometrioma, every now and then there are surprises, and there are some other types of ovarian cysts that can be confused as endometrioma fluid. And so while we can have a pretty high certainty if we see something like an endometrioma that there's endometriosis there, and MRI can be great to predict like nodularity on the rectum and disease in the bowels, there still is not 100% certainty from MRI or imaging that it is endometriosis for sure, right? And so the only way to truly diagnose it is with surgical excision, and then putting it under the microscope, and then a pathology doctor looks under the microscope and looks for the specific cells, right? Right now, there is not a completely uninvasive test to do that. We have blood tests that could show elevated markers on certain things, but they're not, we're extrapolating and using markers from other things. And there are endometrial biopsy tests that we could have a strong index of suspicion. You know, there's a lot of research teams working across the world for different ways to diagnose endo without doing surgery. But right now, there's not one perfect test that we can do without doing a surgery. We can combine all these things and have a very strong suspicion of it, but it is diagnosed 100% with certainty with surgical excision.
Okay, that makes sense. And then I'm not sure about this question, but I think it's regarding like our excision specialist, endometriosis excision specialist, covered by insurance.
So that's a good one. So it is a long-winded discussion on that one too. So some endometriosis excision specialists work in network with insurance and are at university hospitals and things like that, and they can completely take insurance because the hospital pays them a salary for what they do with surgery. And so there are options like that for patients. There are a lot of excision surgeons around the US and world that are out of network with insurance. And It doesn't mean that they don't work with insurance,
Right.
but it means that they don't work completely in network with the insurance, meaning they accept whatever the insurance will pay. And that is, that's a heated topic of discussion. And it doesn't mean, you know, even for my office and practice, and a lot of them, we do negotiate with the insurance. We argue a lot with them on your behalf, and we get them to cover as much as possible and try to reduce your costs. But we're always trying to fight for the insurance companies to pay for the work that we do in the OR and the risk that we take, right? So, and a couple years ago, there were some major changes in the endometriosis world due to the work of multiple people, but especially Dr. Ted Lee, who helped to get a lot more diagnosis codes for endometriosis on the map. So before, there was only one code for all of endo, whether endo invaded your ovary, your uterus, your diaphragm, your liver, your, you know, lung cavity. It was all one code for endometriosis, which doesn't really make sense. Now they've introduced like over 100 modifiers to describe where endometriosis is sitting. And that's very exciting.
Yeah.
So far, there's still only one code to pay for endo surgery. And that code includes, shockingly, diagnosis of endometriosis by just looking at it with the scope, just diagnostic laparoscopy, not removing it, full grading or burning it, or excising it. That code is supposed to compromise all of them.
All of it.
All of it. So
Makes
whether
sense.
a surgeon goes in and just looks at it and doesn't do anything for your endo, whether they go in and just burn a few spots, or whether they spend 9 hours excising it, doing bowel resection, thoracic cavity work, that code for $300 or whatever is supposed to cover all of them.
Right.
And so that's why there's a very big fight in the endo world to get the surgery compensated, to get the surgeons compensated for all the time and the effort they put into multi-organ surgery training and the risk that you take when you do bowel endometriosis and you go into the bowel and you repair it and you have a possible leak and a possible colostomy bag and all these different things is a very different surgery than someone that just goes in and looks at it and then gets back out. You know, that's a 5-minute surgery versus a 9-hour surgery. And
yeah,
so
and all of the other providers that you have to have on call
correct.
and in the surgical room helping you.
Correct. And the call afterwards and the, you know, the case I did a couple of weeks ago that involved multi-organ systems, you know, it's a very different post-op care and relationship and things that you take on for those patients rather than just doing a 5-minute diagnostic scope. And that's why most of us endosurgeons, if we're not on staff with a big university department, we cannot afford malpractice wise and liability wise and all these other things to be completely agreeant with insurance and do whatever they say and only get paid the very small amount for endosurgery. It doesn't make sense, and you can't maintain a practice like that, unfortunately.
Right.
So hopefully things will change as time goes on. But right now, most of us are just fighting the good fight, fighting the insurances, trying to get them to pay as much as we can, staying out of network, trying to do a network when we can. There's complicated ways, but you know, my office is always happy to discuss with people on how to do it. And some plans do work better than others for those agreements and things like that. So Aetna, United, Blue Cross, are some of the plans that work best, but there's obviously ways to do it. And we're always happy to talk about it. You know, certain plans require that you stay in network, and plans require that you stay in network in your state, even you can't go out of state. So it always depends on what your plan is. And, you know, our office is always happy to look into your plan for you. Even if you don't book an appointment, they'll always call your plan and talk with them for you if you wanted to have them look into that for endometriosis, you know.
Awesome. Yeah. I think that was pretty good. Didn't get too much. I get really frustrated with insurance, so I try to just remain calm. Tara, remain calm. Does endometriosis go away after menopause or as you get older?
Very good question. So I get this one a lot. So menopause is not magic. A lot of patients do feel better when there's less estrogen on board with endometriosis. But endometriosis, if it's there and it's not removed and it has caused, for instance, a bowel nodule or adhesions between the bowel and the back of the uterus, going into menopause, is not going to make those lesions and adhesions evaporate. It's not magic, right? It doesn't, and that's what I mean by menopause is not magical. And then in fact, if you do hormone replacement in menopause and someone just gives you an estrogen patch or some Premarin or something, and they don't give you a balanced approach to hormones, then your menopause hormones may actually worsen the disease and the symptoms. And so I have found some patients that's happened to, and I've seen patients even in their 70s with endometriosis still, and that have been postmenopausal for 15, 20 years, and they've still had endo. And so no, menopause alone is not like a quick fix for endo. And unfortunately, there's a lot of people in medicine that have told patients that over the years, and maybe because they had menopausal patients that felt better in menopause, and so they said, oh, menopause is the cure, right? Or hysterectomy is the cure, or something like that. But the important thing is that those things are not the cure. Some patients do feel better in pregnancy, do feel better in menopause, but we can't extrapolate that to the whole population. Endometriosis can and will still persist, and some patients may have problems more with it after menopause, some may not. But we can't generalize that. If the lesions are still there, the disease is still there, fibrosis, scar tissue adhesions, then they may still have issues. Even when the lesions are not swelling and responding to hormonal triggers anymore, the fibrotic nature of the disease, meaning the thickened, deep set inflammation and scar tissue around the disease and the connections between organs do not go away with menopause or and of course not with hormone stimulation either.
Right. Yeah. And I get that question a lot. It's like, you're in so much pain, why don't you just get a hysterectomy? Mm-hmm. It's like, well, yeah. But it doesn't, like, if you do get a hysterectomy, whether it's partial or all the way out, like, I could still have endo on my gallbladder or endo on my appendix that's still going to cause pain and inflammation and problems.
Right. And so that's very important. So listen, and I'm not knocking hysterectomies, right? Hysterectomies can be fantastic and great. And they really can provide a ton of pain relief for patients, especially that have had primary uterine pain for years. But if you're having a hysterectomy for endometriosis, the important thing to remember is that you want to make sure that your surgeon is actually going to remove endometriosis at the same time as the hysterectomy, and remove all of the implants, scar tissue, disease, fibrosis, as well as the uterus. And so making sure that your time under anesthesia, everything possible is fixed that they can, and to reduce your risk for the future. And then I always, have long discussions and debates about the ovaries and what will be done with the ovaries and the history of endometriomas, recurrent cysts, or if not, no recurrent cysts and the ovaries are fine and healthy, then there's always lots of pros and cons about what type of hysterectomy is done if the ovaries are left in place, if one ovary is removed, if both ovaries are removed, and all of the different options. And so I like to tell patients very many different options, and then we have lots of discussions and choices about that before surgery. So
cool. Okay. I don't know. So for patients with silent endo, is that like the correct term for that?
Yeah, you can call it silent endo. Yeah, with infertility.
Endo with no symptoms, I would assume that. What is the recurrence rate post-lap? And I think this question came from somebody going through infertility. They had stage 2 excision, and then they're like, I didn't have any symptoms or any pain or anything to like be indicative of
if it's coming back.
Right.
Yeah. So that's a great question, right? And I have one patient who had very, very severe disease, and hers was silent, meaning asymptomatic mostly. I mean, there's still some little clues there when we really look back at stuff with her and her family. But for the most part, she was pretty asymptomatic. And so for patients like that, I will follow them regularly, once a year, every 6 months, see them, make sure that we know if anything has changed or developed. An experienced endometriosis surgeon still can do an exam, and on a pelvic exam, feel the back of the pelvis. And if it feels fibrotic or if it still feels free on exam, you can tell how things have healed and if there seems like there's any recurrence. So even what we call silent endo, if there's other things that creep up over time, like digestive symptoms, that could be a clue for endo, painful intercourse, infertility with things not working, and then continued hormone stimulation, then these are all things that we should look at over time. And if the patient is truly asymptomatic completely before, no painful intercourse, no bowel symptoms at all, and IVF or infertility is the only thing they're dealing with, that is, and not to say only thing, it's a terrible thing to deal with, but I didn't mean to minimize it that way. I mean that's the only real symptom of endo, right? And then basically, we could still follow it up like yearly or twice a year, not twice a year, or every 2 years with imaging of the pelvis, just to make sure there's no ovarian cysts or anything recurrent that we could actually see.
And it's probably dependent on their IVF like medications too, and their protocols, right?
Correct. And then if they get pregnant, great. And then if they're postpartum, I always advise breastfeeding is great for endometriosis. It's very high progesterone levels that you don't get many times else in life. And most patients do feel great when they're actually pregnant and breastfeeding with endo. So there's things like that where we could do prolonged breastfeeding until they're ready to try again, or things like that could help reduce some of the symptoms of endo. So
I always thought that breastfeeding was beneficial for endo because of the progesterone levels, but then I saw a research article saying that high prolactin levels can negatively affect endometriosis.
With breastfeeding or in general?
I think it was in general. I don't know if it was specifically with breastfeeding.
Might be in general more with prolactinoma or uncontrolled prolactin rather than the breastfeeding itself. And that might be the progesterone balance,
Okay, that makes sense.
I would, and you can send it to me, but I would, and I'll read it. But I do think it's probably more in reference to prolactinoma that's uncontrolled.
Okay, so me again.
Yes, my dear.
All right. What is my first step after diagnosis to correcting endo in stage 4 adeno? I didn't know there were stages of adeno.
Wait, say it again. Say the sentence again?
What is my first step after diagnosis to correcting endo and stage 4 adeno? It's killing me.
Okay. Well, that one, I'm not sure if they've had surgery and removed the endo and then still have the adeno. Those are all sort of different approaches. If they have had surgery for endo and had it all removed, but still have adenomyosis, it depends if they're trying to get pregnant or not, really, on protocols they would use. And then if they're not trying to get pregnant, options to control the uterus for adenomyosis suppression would be low dose hormones or an IUD to suppress the amount of bleeding that they're having every month. There's different options there versus something that's non-synthetic hormone, a little bit trickier with adenomyosis, but there are options with that as well. But yeah, that's sort of a big question. I don't have enough information to really answer it. Yeah, that one probably would need a whole consult for that.
Yeah. Is your expertise extended to fibroids?
Fibroids. Yes, I do a lot of fibroid surgery as well.
Okay.
Yeah. Fibroids are generally a lot easier to deal with than adenomyomas, so adenomyosis and adenomyomas have sort of like branching tentacles into the uterine walls. They don't always come out nicely, whereas fibroids are usually encapsulated in a little shell. And so they come out sort of like an egg or a rock or something like that. And so they're they're much nicer to repair the uterus after fibroid removal than adenomyosis removal. So
can you just share a video of a fibroid removal too?
That one has a huge fibroid. Hasn't had the surgery yet, but we'll be showing that eventually. But,
okay.
Yeah.
Because I thought that was really interesting.
Yes.
But I like that kind of stuff. So, oh, this is a good one. Would you recommend lap surgery before IVF or after IVF?
So that's like a bit of a chicken before the egg question. So it depends what they've had before with their history. If they've had IVF before multiple rounds, if they've, what the situation is, what the endometriosis looks like on ultrasound, if there is visible huge cysts or not, I always work with, and I'm not pushy either way, obviously, if the patient has 3 rounds of IVF covered and they want to try to do egg freezing or embryo freezing first, then that's great. You can always try. If the results are poor and they're getting no blastocysts or no eggs, then there may be a role for laparoscopy or robotic surgery for removal of endo and then IVF afterwards. But we can always work the fertility team on before and after and work in conjunction with them. And it can always be undertaken the surgery after the fact. It really just depends on how everything is going and if they're having good results versus if they've already been trying for a long time with failures, then, sometimes there's a role to just clean everything, flush the tubes, look inside the uterus, biopsy inside there, clean all of the endometriosis, not touch the ovaries unless there's cysts there that need to be removed, and doing basically a fertility optimization surgery, is what I like to call it. Whereas everything is sort of whistle tooth cleaned and primed and ready, and then they can undertake everything again. So
okay. Can you get? I would assume they're saying an LH beak, or ovulate when your tubes are partially blocked.
yes, yeah. So
because that's hormone, right?
Yeah, it's hormone related and it's related to the ovarian stimulation and ovulation itself. So the tubes being blocked has nothing to do with whether the eggs will actually come out of the ovary and ovulate. So your ovaries, while they share sort of like a curtain, the mesosalpinx between the tubes and the ovaries themselves have a separate blood supply and stimulation from above. And they will keep ovulating even if the tubes are not working. They will still keep ovulating every month, theoretically. If you don't have PCOS or some hormone condition that the ovaries are not ovulating every month, they will usually keep going. And even if the tubes are removed or don't collect them, the eggs are released into the abdomen. They're microscopic.
Oh, okay.
Yeah.
Huh. So they just wouldn't go down the tubes because they're blocked. Mm-hmm. And does the body just like resorb them?
Yeah.
Oh.
I mean, it happens most months, right? Not every month the tube actually picks up the egg successfully. And so, if patients have had tubes removed, then they're just released into the abdominal cavity.
Huh.
So, yeah.
That's kind of interesting. Mm-hmm. I never thought of that. Do you recommend taking hormones as endo treatment post-surgery? We kind of went over that a little bit, right?
Yeah, we went over that. That's case by case, depending on what they tolerate and what their goals are. If their goals are not to bleed at all versus not to ovulate at all, or not to have any of them versus they want to feel things, it really depends. So
okay. And then we talked about how soon after excision can endo return. It's very case by case basis. Mm-hmm. Are you accepting new patients?
Yes.
Okay. Can you have endo and no symptoms? We kind of went over that. Mm-hmm. What's the difference between...
I think for that one, I think it's very important, given your platform, Tara, is that you can have endo and no symptoms, and 50% of cases of unexplained infertility are caused by endometriosis, right? So unexplained miscarriages, failures of IVF, failed transfers, difficulties in the pregnancy complications, miscarriages, whether it's first, second trimester, stillbirth, placental abnormalities in the pregnancy, all different things are risk factors that actually may be caused by endo. And so even if you don't have symptoms, it's very important if you're an infertility patient that you should be thinking about endo, or your doctor should be thinking about endo if they cannot find a reason otherwise. If you don't, have, okay, PCOS and we just need to give you a little bit of this and then it works on the first or second time. If you're having really a lot of difficulty with it, then endometriosis should certainly be on the table, since it causes 50% of unexplained infertility.
And
So I think that's very important
too, like as a community, like we think of symptoms as pain or heavy periods or like your typical well-known endometriosis symptoms, but unexplained infertility is also a symptom. And like other things that aren't directly related to pain are considered symptoms too. So,
and I think it's important to highlight that, like you're saying. I mean, not all patients with endo have painful periods, right? And so, yeah, it causes painful, debilitating periods, but not everyone, right? So I had endo. I spent my whole 20s, I had different times on low dose birth control, but I mainly had bowel symptoms and was diagnosed with IBS or beginning Crohn's or celiac. And I was diagnosed with all these things before I was ever diagnosed with endo. And that was really, I had bowel predominant disease. And my own grandmother had endo, but they had terrible, debilitating periods. And so even they were like, meh, you're not really having the same things we had. You kind of have bowel problems. And when I finally had endo diagnosed at like 30, 31, it was all around the bowel, and my IBS like went away. And so it was fantastic. But it's, so that's why it's important that we don't say, okay, well, you have to have painful periods, lower back pain, leg pain, this bowel symptom. No, you don't have to have all of those. You may only have one of those things, or you may just have infertility, or you may just have painful intercourse, or you may just have bloating or something, and it may be endo. So everyone reacts very differently to this disease, and there's no correlation between the depth of invasion and the symptoms it causes. So it's very frustrating to patients and to clinicians alike. It's hard to predict how bad it is based on the depth of invasion and things like that, based on the symptoms. And so that's why it's very broad, so.
Because like when I was younger, I went to the emergency room multiple times because I thought I was having appendicitis.
Right.
And it wasn't just during my period either.
Yeah, it may have been random times in the month. And it's interesting you say that, because even that patient that I presented a few weeks ago that had liver herniation into the lung cavity and lung collapse and had just done IVF, and she presumably had no endo symptoms. But when I talked further to her and her husband, she had several ER visits over the years for random things. And when we look back at it, it probably was endo all along. Like some ER visit, they thought maybe the appendix. Some ER visit, they thought this or whatever. And most of the time, day to day, she wasn't in pain, but she did have a couple of ER visits over the course of 5-6 years that, the general public doesn't have. And so, yeah, these kind of things commonly in ER, they'll say, oh, it's not the appendix, you're having ovarian cyst rupture. And why do they say that? Well, if you say ovarian cyst rupture, it's ovulating. Every month you ovulate, you have ovarian cyst rupture. So if they say that, nobody's ever really wrong, and if there's a little fluid around the ovary, medical legally, oh, it's ovarian cyst rupture. Well, every month you have an ovarian cyst rupture. You're theoretically ovulating. So yeah, you can't exactly be wrong if you say it's a recent cyst rupture, or you're about to have cyst rupture, because you ovulate every 4 weeks, right? So yeah, that's a confusing thing about ER visits, but it can happen that way. So
I think that you kind of went over what the difference was between excision and ablation. Repeat surgery. And then another question about insurance, self-pay. If self-pay, how much? Just a lot of like insurance related questions. I don't know if you want to get into that or just have them call and
if they want to call if they want to call and ask the office, they're happy to do that. It really depends on if you have any plan at all, if the plan covers the hospital itself. There's every single, even for someone to say, oh, I have United, it depends on your employer, what that employer covers, what your percentages are, all this stuff like that, what deductible you've met, there's all kinds of different things. So yeah, if people have specific questions, then I'm happy to, they're welcome to call the office, and, my surgical coordinator can reach out to them, or, we can go through stuff like that with them. But yeah, it's way too varied to make a general approaches about it.
And I think the biggest thing, like with me when looking into all of this stuff and trying to find a provider too, was the hospital that you operate out of is a different benefit than you specifically as a provider. And that is, I don't think a lot of people understand that either.
Yeah, it depends, right? So I work at different hospitals, but I'm not employed by the hospital, right? So the hospital doesn't pay me. And when I do surgery, actually, and I bring a patient to a hospital, that means their insurance will pay the hospital for the surgical fees, the OR, the equipment, all that, things like that, and the anesthesia bill and things like that. But their insurance will pay those people directly, and I won't see any of that, right? So the insurance will basically pays providers in all of the different levels of care, and the supplies and stuff like that goes to the hospital. Anesthesia is with the hospital. Facility fees for the OR time, every hour you're in the OR, they charge a certain amount. And all of those things are actually billed by the hospital and paid to the hospital. Insurance companies are contracted with the hospitals, and they get paid like within a week or two. They actually get paid. The hospitals get paid.
Do you imagine?
Yeah, it's wild. Surgeons may take anywhere from like 8 to 9 months to 2 years to be paid for their fee. So it's very important to understand the difference between all of that. Unless they're on faculty at a hospital with a contracted rate, then they probably will get paid very quickly with that. So
yeah. Okay, and then now, do you have time to go over my plan, or?
Yeah, the floor is yours.
Well, so I don't know if you want to just like explain what you're going to be doing. And so I have a bicornuate uterus. I have a prolactinoma. We do have 2 embryos left, so that's a consideration. And then the main thing I kind of thought was interesting with what your plan is for me is I have a bicornuate uterus, we think, right? Like officially.
Yeah, so I was actually just zooming in, and so for you guys that are watching, I do not have an MRI or a sonogram on Tara yet, an ultrasound on Tara yet, because she's coming in person in 2 weeks, and we're going to get an MRI. But I'm actually relying on past history and then her laparoscopic views and hysteroscopic views, which is the views inside the uterine camera from her surgery in 2020. And I'm not looking at any imaging right now. I don't have it yet. So this morning, what I did, actually, I'm looking back at your laparoscopic images again, Tara, and I do see one of the views. So, and this is tricky, right? So I'm going to see if I can do this. So when we look at this view, it's hard to tell, but this is the ovary, this is the tube, this is the uterus. It almost looks like a normal uterus on this view. And this is the ovary and this is the tube.
And then the tube, that's my endometrioma, right? Or is that not?
This is your right side, and the tube does look swollen there. There's some paratubal cysts here in the tube. This is your ovary and this is the uterus. Now, what we don't see here is actually the other part of your uterus. The other bicornuate part is here in the shadows. And this is the way, like I'm looking at this picture, I can't tell, and it's very subtle. I don't know if I can show this properly. It'd be better on Zoom. This is the bladder. This is bladder peritoneum. Back here is actually the other half of the uterus. I can barely tell, but there seems to be a very subtle outline that I think this is the other part of the bicornuate. Now, when I look and I slide over and I zoomed in on this picture.
I think, that was the one that
this is the better. Hold on, let me see if I can show that. No, this is not there. Let me see. That will work better. Okay.
That's the one.
This one better shows it. I'm gonna try to use my letter opener here. All right. So this is the ovary. This is the
Yeah.
tube. This is part of the uterus. This is the other part of the uterus, and
Yeah.
this is the bicornuate. This is sort of the midline in the uterus. And when I went back and looked at this on Zoom, this is what they're talking about, is that it does look sort of like,
An indent.
did you ever watch
or...
Hey Arnold, and he has like a football head? Do you remember that? So where we see this other uterus, this is a normal size uterus.
Okay.
What you have is almost a duplicate completely. You have like two of those together. And I think that this whitened part is the midline portion of the bicornuate.
Okay.
And it looks paler white, and we just can't see it in this view. It's like behind here in the shadows.
Okay.
And so when I first looked at it, it looks like a normal uterus from this part, but then you can't see the other half is hiding here in the shadows. When we look at this one, it looks like it's still in the shadows, but I think that this is the second half of the uterus. And we're going to see this better on the MRI and the imaging. And then of course, but
once you get in there.
Yeah, but what they're saying is, and when we look back at your operative report, was when they put the hysteroscopy inside the uterus, they see the thick broad-based septum, but then when they push on the middle of the septum, the camera light actually goes right here in the middle of this line.
Okay.
So they said when they pushed the hysteroscope to the middle of the septum, it appeared soft and like it was normal endometrial cavity. But then when they pushed the light on the inside hysteroscopic view, they can see the light on this midline portion of the bicornuate.
And what does seeing the light mean? Like it's thin?
It means that, it looks really thick, that septum on the uterine view, but yeah, essentially it means that it's a thin part there that if you don't have enough tissue to overlap it, then it's a lot more reconstructive work, like what we were talking about, the metroplasty and the certain procedure where people have joined two uterine horns, opened up the uterus at the midline where the bicornuate is, remove fibrotic tissue and then refuse them together. And that's a very big surgery for the uterus. It's called Strassman's metroplasty. It's not impossible, but there are a lot of risks involved with it, right?
Okay.
And so big risks being uterine rupture when carrying, and there are successful cases of this, of course. I have this one case report I'm looking at from 2017, but even in the case report, if you read between the lines, the patient, it looks like, had bowel adhesions. They delivered at 35 weeks. There was placental abnormality. They thought the placenta invaded into the scar site. They had early admits to the hospital, things happening, so it's definitely not a low risk pregnancy afterwards, right? And they had to wait at least 6 months to get pregnant afterwards. And you carry the risk of knowing that the uterus has been completely bisected completely. So this would be the same as if someone has a classical midline up and down incision on the uterus and then carries afterwards, then it's an early delivery before contractions and intensive watching,
right,
to make sure that everything is fine. So it's not as if it's low risk, of course. And for your case, of course, there's a lot of ups and downs, and what does everyone know what's happening with your story?
I think so.
With a carrier and everything? Yes. So we know you have a baby on the way.
Yes.
And so we know that, we need to keep everything safe and take risks versus benefits into very careful consideration, because we have a tight timeline before baby's coming, to make sure that, we're doing the best thing possible to help you relieve pain, but then also think about the future and what are the options and what are the best options for you. And we've talked a lot about this already, but basically, you had endometriosis excision. We do think that there's still residual endometriosis based on the OR report on the bowel in different places. We have a team ready already. There will be a bowel surgeon there to help we're planning to remove endometriosis from wherever it is. We've talked about, the ovaries appear healthy, but we're doing imaging right before the surgery, also to evaluate the kidneys. Due to Tara's uterine anomaly, bicornate uterus, there are commonly, renal or kidney. Sometimes the kidney can develop in a different place, or there's a uterine anomaly, like 2 ureters on one side or things like that. And I always like to look at that before doing the surgery, especially with the uterine anomaly, just to make sure that we're aware of all these anatomic abnormalities before going in for surgery. So we're going to be doing that. But basically, the big question is with the uterus itself, what is possible, and looking at the imaging and looking at the uterus itself, and then looking at the risks versus benefits of fixing the uterus, and for what purpose we'd be doing that, right?
Yeah.
If the risk is too much to take to carry, then Tara and I have talked a lot about pros and cons of fixing it versus if it's too big of a risk to carry and it's not advised to carry, then does she want the uterus? Did you want to undertake a major surgery like that with risk of severe bowel adhesions and things like that versus have a surgery that's more definitive for pain?
Right.
So.
Right. And I wanted to touch base too on what you were talking about with like the backflow with uterine anomalies. So like the shape of the uterus, instead of having your menstrual cycle go down, like having your period go down and out, it's more likely to go back and into the abdominal cavity.
Yes, so that's called retrograde menstruation. And it does not mean that retrograde menstruation causes endometriosis per se or anything like that. But retrograde menstruation itself can make you feel, I think, can make patients feel a little bit more of inflammation in the abdomen, that ill sort of malaise feeling during the period, or if you're cramping very hard but bleeding isn't coming out as fresh red blood, it's coming out as dark clots, or you have a day of heavy bleeding, then you stop bleeding for a day but you're still cramping really bad, then you start bleeding again. These are all things that could happen with a uterine septum or a uterine anomaly. That means that the bleeding is not always moving forward and correctly coming out of the vagina like it should. And so whenever the blood goes backwards, that's called retrograde bleeding. Some patients can tolerate that and have that, and they have no pain from that or issues. Some patients with retrograde bleeding can have as much as a cup, or I've seen even a liter of blood into the abdomen with a period. And that can make them feel very sick, and inflammatory signs, peritoneal signs, or, nauseous, abdominal pain, not well with the cycle. And that could be worsened by something like a bicornate or a septum. And so that's important to discuss. And there are options with that. If you're not planning, for instance, to, or if you're undergoing IVF already and the tubes have cysts on them or not working, then there's the option for removing the tubes to prevent that from happening in the future.
And so that would be an option for me, because you think there's a high suspect that could be happening.
Yeah, highly likely with the shape of your uterus.
And personally, I'm not doing any more IVF retrievals. My husband and I have already decided that. And we do have 2 embryos left. So if we were to just take the fallopian tubes, that would significantly, hopefully, reduce some of my pelvic pain. And then I would still, if we decide that it's safe to transfer with me, would still be able to do that, even if we take my fallopian tubes.
Yes, they have no bearing on the pregnancy doing IVF and embryo transfer. Yes.
Okay.
Correct.
So that's one option that we're kind of looking at. And then like a full hysterectomy is another thing that we've kind of touched base on. But yeah, that's kind of it. And then my large endometrioma on my right ovary, you were going to try to take that out.
Remove the cyst and repair the ovary, unless you wanted something more definitive with that, then we can do that. But yeah, the cyst can be removed, the ovary can be reconstructed like plastic surgery. I do recommend if you're having endometrioma cyst surgery, that you talk to the surgeon about that, or have the option of repairing the ovary. Why? Even though it takes time, it helps to prevent bowel adhesions from going straight into the open ovary when they leave it open. I've seen a lot of patients that have had ovarian surgery and then they didn't really repair the ovary. They put some adhesion barrier or some Surgiflow or these surgical things on the ovary. And unfortunately, I've seen a lot of bowel adherent right into that spot. So anytime
like
that we have
bowel adheres to your ovary?
Yeah, yeah.
Oh.
A case I did just 2 weeks ago was like that. And both ovaries were fused together and the bowel was fused into the ovaries and to the back of the uterus. And so it created a huge mess. And so if we do ovarian surgery, it's always nice if someone actually does repair the ovary. It reduces the risk of bowel adhesions into the ovary.
Okay.
You know, we do fibroids, we repair the uterus, right? We do surgery on the bowel, go into the bowel, you repair the bowel. You do it to the bladder, you repair the bladder. For some reason, ovaries have gotten a poor, the poor ovaries have people have said, oh, well, you don't need to repair them. And you could just, if the bleeding is controlled, then just leave them open. But it's not great. I've seen a lot of surgical adhesions post-op after that, and seen patients come back with extensive pain or bowel symptoms or things happening because everything, you have to remember that blood is like a perfect glue for things to stick together. It's sort of like, I always tell patients, if you fall skateboarding, I'm not skateboarding, don't worry, but if you fall skateboarding and you get a huge gash on your arm, you're going to put some Neosporin and a bandage on it before you put your sweater or your shirt on, right?
Oh,
why? If your arm is bleeding and you go put this on and then you go to take it off later, it's going to tear this open and I'll start bleeding again. It's terrible. So blood and a bleeding organ is a perfect thing to stick everything together. And so,
okay.
So yeah, meticulous bleeding control is the best way to prevent adhesions. And if people are not doing that in surgery, then there could be high risk of adhesions. So when you do multiple surgeries, that's very important, is how they control bleeding and how things are repaired, So.
Okay. And now with my last laparoscopy, did she just drain that endometrioma? I think that's what, or did she try to remove it?
Let me see. On your operative report,
because right before
sidewall, cul-de-sac, endometrial biopsy, appendix, and a paratubal cyst. I don't see an ovarian cyst on this biopsy report. Hold on, let me look back again.
Because right after, like, my first laparoscopy, we were getting ready to do IVF retrievals.
Mm-hmm.
And so my biggest concern was to do everything we possibly can to save my ovaries.
Right.
And so I was curious if she just drained that, because I've had it forever.
It says normal.
Oh, you're breaking up. I can't hear you. What did you say? Yep.
On your operative report, it says the findings were normal bilateral ovaries. So it does not seem that there was anything done with an ovarian cyst on your surgery.
Okay. So that endometrioma might be on my tube?
It might be on the tube, or it might still be there in the ovary if it was at that time. This says, let me see.
Because every single time I have an ultrasound, there's at least 5 centimeter
endometrioma,
something dark spot on the ultrasound.
Yeah.
Like every single time.
Yeah, this says, this does not say anything about ovarian cysts. It says that they appeared normal and the paratubal cysts were removed.
And so those paratubal are on my fallopian tubes.
Correct.
Okay.
Yeah. But yeah, one does wonder if the cyst is still present, then it wasn't the paratubal cyst on imaging before,
Okay.
Like that. So
I'm
Yeah.
very curious to see what you find when you get in there.
Yeah. Yeah, and we'll see about the MRI too. Ahead of time, we'll have a look at all of it,
Yeah.
and we'll have the final look at the uterine walls and everything like that with the MRI images. And, they're able to, at a good place, do a lot of imaging, and I'll ask them to measure the septum and then the depth of the walls and things like that. And we can look at that ahead of time. So even though we're doing it right before surgery, it still helps us to talk about, what are the options and what are the best options for you.
Yeah.
So, yeah.
And then last thing I kind of want to touch base is just like this whole week, like what it looked like to get preoperative approval. So I had to go to my primary care and get an EKG, blood work, and what else did I have to do? EKG, blood work, and a physical. And that tells you that I'm fit for surgery. Like I will do okay with the anesthesia and things like that.
Correct. Yeah, the
And
anesthesiologist in hospital will look at all of that. And so
okay.
we have all of and I already got a copy of your pre-op blood work, and it tells me you're not anemic. You have no sign of infection. There's no white blood cell count. We check your coags, like your clotting profile, that looks normal. They do a pregnancy test, that's negative. Your prolactin was elevated, but only slightly. So the range is 5 to 37. Your prolactin is 38. So it's probably not as bad as it used to be, but
Yeah, but this is 2 months bromocriptine.
Yeah. So it's slightly above. Your blood type is O positive. And then it shows trace inflammation in the urine, leukoesterase, but no infection that they see. So kidney function looks good. Liver function looks good. So this is what all of these labs show. And urine culture is negative after 36 hours. So even though there was a little inflammation in the urine, the culture was negative. So that's what all these labs show.
I'm curious to see if there's endo on my bladder and
If that's
all that stuff too, because I've been having some symptoms with that.
Mm-hmm.
But so all of that, in order for you to know if I'm a candidate for surgery, was done locally with my primary care. So that's something that we could do locally. And then as far as like the imaging, I'm going to New York to have the MRI and ultrasound done.
Probably just, we'll do the MRI for sure. I do the ultrasound in my office too. I do an ultrasound in my office. But yeah, we had talked about maybe a 3D ultrasound. I'm still going to talk to East River on whether they recommend that or whether they're able to do enough from just measuring the septum themselves on the MRI images. So,
but
so I'll have.
If someone was traveling to you out of state, that's something, the MRI and the imaging is all stuff they could have done locally?
Yeah, they can. And if the imaging, if you're having it done locally, I always want them to get a copy of the images on CD and send it to us. Or if they have portal access to be able to look at it. If I need to get a reread by someone in New York that does endometriosis all the time, like a radiologist that does a lot of endo, they can use your images and reread it. But typically the radiology center needs a disc. They are not going to like log onto a portal with your password or something like that, or get a portal access for some random place. They just want the disc in front of them. They want to put it in their system and
read it. Yeah.
And so that's a possibility if the images are good enough. They can't say for sure what the quality of the images are, but in these MRIs have different capabilities based on what machine they have and things like that, as you would expect. So, but that is a possibility. People can have them done ahead of time, and then we could always have them reread. It's easier to get the disc when you're there that day for imaging, and they say, hey, do you want to get the disc for $20? Say yes and get it and take it with you, because it's always good to have it on hand. The report alone, some people miss endo, and so it's not good to just have the report. It's good to have everything, the images too.
And like, as for me, I decided to go a day early to New York and have all of my imaging done with the people that you trust and you like.
We're working with a short timeline for you anyway, so it's different for you. If I was seeing someone and I wasn't doing surgery for a few months and we wanted answers ahead of time, then I would do the MRI locally, and then we could always reread it if needed, or look at it and try to. The radiology place that I go to, they actually give patients the report, but then also like a 2 or 3 page cheat sheet on all the highlight images, like this is the most important images. And so they'll do it for you with the bicornate, you know, and so it's nice because you get to take that home with you, you have it, and then whatever doctor they're sending it to also has a preview. You know, we're not radiologists, right? I'm not an expert radiologist, but they'll be like, hey, here, right here, this is the arrow, this is what it is. And so it's really nice. It's educational for both the surgeons or your doctor and for yourself to have a copy of that. So that's what I like about the places that I use. And they do take insurance, and we get it authorized by insurance so that they cover it. So that doesn't matter if they're doing a reread. Typically insurance doesn't cover a reread. So that's why we want the whole, sorry, I'm not meaning to share balloons.
Send balloons.
Yeah, I know you were doing something earlier and it started doing hearts. Yeah, it was funny. So yeah, the MRI places usually will cover one MRI. They won't cover the reread of the MRI.
Okay, so that's a good thing to know.
Yes. So if you want it done at a certain place, then it's good to ask them about, you know, if you can get a copy of the disc and the images, and if you need to do a reread. I think our place charges, I think they might charge $250 to do a reread or something. The radiologist does have to sit there and review it for an hour or something, so that's paying for their time. So yeah, that's what you could do. I'm sure you can use HSA for that or something and then submit it back to your insurance, but they don't always like to pay for second opinions on things. So
okay, and then I'm coming for and then we'll have surgery. And then you come and check on all your patients after surgery.
Yes. So with the caveat that they're staying nearby the office or the hospital, right?
Okay.
So if you're staying like an hour or two away, that's hard for me to do, obviously. The hotel right near my office is literally next door to the office. If a patient is having something more extensive, they're staying overnight at the hospital, then, you know, I will likely go see them at the hospital. Or if they're coming, some patients rent a house nearby or something like that. You know, there's different options, or Airbnb. And then there's also the option, obviously, of coming to my office, and, you know, those are all different options. So it depends on the case with the patient, you know, and where they're staying, things like that. But certainly if it's that place right near the office and they're not feeling like coming to the office, then I'm happy to stop by there and round on the patient at the hotel.
Okay. And then at that post-operative appointment, you clear patients to fly home. Is that? Okay.
Yeah.
And then that usually.
And typically it's like a couple days after surgery is okay.
Okay.
Again, it depends on how extensive the surgery is. If there's, for instance, bowel work done, if there's diaphragm work, you know, the patient that had surgery a couple weeks ago that had her diaphragm repaired, she's not going to fly right away, you know. So it always depends on the case. But if it's straightforward and there's no extensive work done if there's work done on the bowel, then I like to see the patients have a bowel movement first, you know, and make sure everything is fine. If there's extensive work done, then it may need a longer stay here in New York, or if they're local, then longer stay before they're traveling.
Okay.
You know.
And then you do like a 2-week post-op visit. Is that right?
So typically, for your case, since you're coming right into town, you know, I'll see you right after the surgery, and then we'll chat before you leave, and then we'll touch base. I usually like to get a message or an email or something that you guys have made it home safe. And then we'll do a follow-up once your pathology is back. And so some hospitals, it takes a few days, some takes a week or 2 weeks to come back, the pathology. And once we have that, then we can go over everything, all the results.
Okay.
Yeah.
And that's usually through telemedicine.
Yeah.
Okay.
Yeah. Unless you're around, then we'll
here. Yeah. All right. I just thought it was really awesome how you had everything coordinated and like a protocol, and it was just very easy. So because it's daunting to like go see like the best surgeon when they're not local to you either. So that it was very easy, and I was surprised.
Well, good. That's why we're trying to make it that way. So we're trying to take the headache out so that the process is very easy. So
and so that people can get the care that they need.
Absolutely.
And then I don't think we had any like major questions that people, let me see, put in there. Can tubes be unblocked to achieve a pregnancy at 42?
So I don't know if they mean they've had a tubal, like they've had tubal surgery to block the tubes before, or they're having a block tube from endometriosis or things like that. That depends on the case. If there's endometriosis or something on the tube, or there's adhesions around the tube, the adhesions could be removed, and the tubes could be flushed. As far as doing surgery to reconnect the tubes, if they've already had a tubal ligation, that's a little bit riskier as far as, most IVF doctors do not recommend doing that at this point. I know that they do that to reverse vasectomies. It's a little bit different with fallopian tubes. The reason being is because it puts you at a lot higher risk for an ectopic pregnancy if the tube is not normal, right? And so there's always sort of like pros and cons versus with that. And if they can achieve or obtain eggs and embryos, then the recommendations are generally, if the tube is abnormal, to remove the tubes and do IVF and implant the embryo right in the cavity where it belongs, rather than putting it at risk for ectopic in the tube. And those recommendations have changed in the last 10 years as IVF has become much better. Before they would try to recanalize tubes and repair them. Now, some people religiously that can't have IVF, then there's certainly cases that they do try that, and so that's sort of it depends on the situation there, but it's not, and reversing a vasectomy, I should say, is not also easy. Reversals, vasectomies take 5 minutes. Vasectomy reversals take 7 hours of microsurgery to reconnect the vas deferens under a microscope and try to get semen to come down the tube. Yeah, and there's no guarantee of it, but it's successful in many cases, but it's not an easy surgery for them either. But in that case, they're still trying to just get semen to come that's normal. Whereas with the fallopian tube, there's a lot of other fallopian tube and the fimbriae to work, like the microcilia, like coral. You're asking for it to work perfectly. Drop an egg, move it carefully down the tube, fertilize in the middle of the tube, then transport it to the cavity. And so that's where, all these microscopic movements that have to occur could be abnormal and, higher risk if you're taking a scarred tube and reconnecting it with suture and putting it back together. Okay.
Yeah, that makes sense. Okay, and then one more. This is such perfect timing. I just got my lap scheduled today for later this month. What does Dr. Goldstein recommend for pre and post-op preparation and recovery?
So it depends on your surgeon and your case. Tara, I give you a packet full of information. I like to do like a packet full of surgical information for pre and post-op. We send that to you guys on PDF, on email, but we also give a little surgical goodie bag of all the things that you need for pre and post-op. I do a lot of bowel preps for patients ahead of surgery if we're expecting disease on the bowel to lower the risk of infection. But that depends on the nature of your disease and how deep the case is suspected to be. And as far as, pre and post-op, eating things either way, you would want to eat light diet before the surgery. Typically, I advise just breakfast the day before and then liquids the rest of the day. And then after surgery to have lots of soups and broths and things like that for the first day or so. Crackers, toast, gluten-free, things that are easy to digest and process, and not a lot of fibrous vegetables right away after surgery. They can create more digestion, more gas pain. During surgery, your bowels kind of freeze up and they slow down. And after surgery, they're trying to wake back up again and you're trying to pass gas. So you don't want to put too much work on the bowels right away. So you want to have things that are well cooked and easy to process, kind of like if you had a stomach bug and you're going to start eating again. That's what you want to focus on for after surgery too, that you're not going to be over aggressive and have like spicy food and pizza and things like that right away.
After your surgery.
Yeah. Yeah. So those are the kind of like nutshell things, but obviously talk to your surgeon. They should have a plan for you before and post-op and on what they recommend as well. So.
Yeah. And for you, that was very easy. It was very well put together, and this is what we do, and you'll get all the things you need. Don't buy that. It was great.
Mm-hmm.
And I think that I didn't see any other questions. We didn't really touch on the bowel prep for me, but that was included in my pre-op.
Yeah.
Um,
So there's a prescription one that's 2 tiny bottles. That's called ClinPick. If the pharmacy or insurance doesn't have it, then you can actually do an old-fashioned one like Miralax, which is the powdered 8-ounce Miralax bottle, and you can separate it into 2 bottles of the Gatorade of your choice, and you can drink that. I don't do those crazy go lightly preps with like gallons of stuff to drink, but you will drink like a small bowel prep and then lots of fluids throughout the day, whether it's not Gatorade, you could do coconut water, you could do chamomile tea with honey in it, but you want a soup with salt in it for electrolytes. But basically, you want to have electrolyte rich fluid the day before surgery to keep up with the hydration, and the hydration
makes sense. And I've been getting a lot of messages too, like you need to have your bowels checked, like you need to have a colonoscopy, you need, like I've been getting a lot of messages with my symptoms on that, and that is something that we are taking care of.
Yeah, yeah. The bowels
So
will be checked.
my bowels will be checked.
Yes, absolutely. Yeah.
And then I think, oh, that was just a statement. I don't think there's any more questions.
All right. If more pop up later, just let me know, and we can always do this again sometime.
Yeah. Well, this is fun.
Yeah,
And I hope
absolutely.
people got a lot of good information from it. And
Absolutely.
if you're considering flying out of state for the best doctor, it's not as daunting as it seems.
Yeah. Well, we're gonna be happy to show all of that. Tara's
Yes.
graciously agreed to highlight it for you guys so that you can kind of have a look at how it looks. You know?
I take everybody along with me.
Yes, absolutely. Do you have one of those camera sticks?
No.
No. You just hold the phone.
I just hold it.
Yeah.
Like you get what you get. We fake it until we make it.
Exactly. Exactly. I love it.
Well, I
Yeah.
appreciate your time, and I hope you have a good rest of your Monday.
Absolutely.
And
You too.
we'll be seeing you soon.
All right.
All
We'll
right.
see you in 10 days.
Sounds
Take care.
good.
See you
Thank you.
soon. Bye.